Alternative Dig Talk. Real issues, real talk.
Hey Teddy, have you noticed how little attention science and health issues get in the media?
Totally, Edgar, yet science information is very important.
Yeah, for sure. That's why the Health Journalists Network is here.
How can they help?
They are a group of journalists dedicated to advancing public understanding of healthcare issues through impactful reporting on health and science.
Oh, really?
Yes, they meet up every month with scientists and researchers, policymakers, and activists at the science media cafes. They then relay what they discuss to the public.
Does that benefit us?
Oh yes, very much so. This helps with health and science literacy for a healthy Ugandan society.
Okay. I love getting informed about science and health issues. Health information makes all the difference between life and death. I'll look them up and engage them.
That's great. They are based all over the country.
Oh, okay. That's interesting, and they should be making real impact.
They are empowering health communities through journalism. Journalists can save lives just like doctors.
The Alternative Dig Talk. Real issues, real talk.
Welcome to the Health Hub. My name is Esther Nakkazi. I'm a freelance science journalist. I'm also the founder of the Health Journalists Network in Uganda. Today we are hosting Mr. Donald Mwesiga. He is the Executive Director of Palliative Care Association of Uganda. Mark, you're very welcome.
Thank you for having me.
Mark is here today because Palliative Care Association of Uganda is celebrating 25 years, and that is a big milestone. And I must say we are proud of you, and we are proud of the association and the work you're doing, Mark. Thank you very much. So let's get into it. Mark, what does palliative care do? What does the association do?
Yeah, thank you so much, Esther. And I'm glad to be hosted today on this digital TV. My name is Donald Mwesiga, and I am the Executive Director of the Palliative Care Association of Uganda. And the Palliative Care Association of Uganda is an association that is a membership organization for all palliative care providers in a country. And by members, I mean individuals. These are health workers mainly, but also caregivers and community members and some patients, as well as organizations who are offering palliative care. The organizations include hospitals, include hospices, and other organizations that are health care related and are offering palliative care. Palliative care is an approach that is utilized to bring comfort and to bring hope and dignity and care to the people who are diagnosed with life-limiting illnesses. We always do our best to make it as simple as possible that palliative care is comfort care. When one has been to the hospital and they have been told that they have a disease in their body and that this disease is going to be treated for a particular period of time, either for cure, and some may not cure, so it is going to be long-term care. They need support to make sure that they go through this condition as they get the treatment, as they adhere to the treatment, but also those who are around them, the immediate caregiver, and also their family, because now they have a condition or a disease that is going to take them some time. So when we talk about life-limiting illnesses, we mean diseases that stop you from doing what you should be doing if you were okay completely. that they slow you down in a way or maybe stop you completely. For example, if someone has been diagnosed with a condition like high blood pressure or a condition like cancer, a disease like cancer, that means the treatment, the adherence to treatment, and the work with the doctors, and the period in hospital, how many investigations and tests you are going to do, you need somebody to walk with you that journey. Now, palliative care starts at that point when the disease has been diagnosed, the life-limiting condition, and sometimes life-threatening because it may end into death. It starts from that point when somebody has been diagnosed through the treatment or curative process until the time of end of life. For example, somebody has been sick for long and so they will not be cured, but they have to be work with the medical people. It gets into when they are at their time of death. That's when somebody, for example, is discharged from a hospital to go back home, not necessarily that they are cured, but to go back home to continue the hospital has done what they could do, as we normally say in Uganda. And now death has come, so the palliative care team will work with the family and the caregiver during the period of death, and also bereavement to support the family to transit now the person into the next phase. The approach of palliative care really looks at the dignity of the person, the well-being of the caregiver, the well-being of the family. It is embracing, it is holistic, it has to look at the physical pain, the pain that somebody has, which is social, or in case somebody has been working and they have stopped, or in case somebody has children to look after. It has to look at the spiritual aspect of the person. It has to look at the psychosocial or the mental health and well-being of the person. So it's that approach that is really holistic and looks at the person as a whole and looks at the individual.
So it's not necessarily that people are going to die all the time. There is also a cure aspect to it.
Yes. So it's a journey that you will move along with the team. The palliative care team will be composed of these professionals. There will be a doctor who will be treating you. There will be a counselor or social worker who will be speaking to you and your family. There will be a spiritual leader, somebody who will be answering questions. For example, you know sickness is tough, and some people, when you are really sick, you have questions. For example, I've been good in this world. Why is it me with diabetes, with cancer, with high blood pressure? Why is it my child with sickle cell? Why me at this point of time? So the spiritual leader will be important. And then we see a lot of mental health needs now in our country, and psychosocial support will be there to support you through the process. And so our association, the Palliative Care Association of Uganda, is the membership organization, as I explained. So we have people across the country who offer this form of care that I'm talking to you about. So far, our association has 30 organizations, and the 30 organizations are mainly hospices and hospitals, but the individuals, the people who are really our members, and the majority of our members are nurses, really, they are over 1,500 across the country. Yeah.
So how far back does this organization go? When was it founded? Who founded it? And, you know, African, I think in the African context, we hear about palliative care, but we do not think about it the way you have explained it. So who is the founder and how did they have this vision? So
you remember about 30 years ago when the HIV/AIDS scourge was really tough, before we transited into the period of ARVs, as I think if I say that, people will appreciate it.
The antiretroviral.
Yes, retroviral medicines or drugs, as you call it. And during that time when we had really people, our relatives, our friends, our uncles, suffer HIV that was excruciating, and somebody would really suffer. Now, that's when palliative care came into our country. In 1993, the Dr. Anne Merriman, who established Hospice Africa Uganda, came to us at that point in time. And she worked with nurses, specifically Rose Chiwanuka and Martha Raboni at the Zambia, at St. Francis Hospital in Zambia, before establishing Hospice Africa Uganda. Last year, 2023, we celebrated 30 years when palliative care services were really specialized palliative care services were introduced in our country. And with the establishment of Hospice Africa Uganda, which was an organization that was a bit different from what other organizations were doing. They were going to the home where the majority of the patients were bedridden and they were dying in agony and suffering and pain. And the approach was that the hospice program, which was going to the home, had a painkiller, a special medicine for pain management called oral liquid morphine. And that was the pain that was with patients would be solved. And then a discussion would commence to talk about the psychosocial well-being, the spiritual aspect, the social well-being of a person, as I told you. And then the family would be counseled and supported to move this journey towards death, because the majority of the people at that point of time, without too much medicine to make sure that there's virus suppression in the body and etc., it was very important at that point in time. So we date back from that point in time. As time went on, of course, with ARVs and the approach of HIV continuing to develop, now the need for palliative care started to be strong in other conditions, like cancer, for example. These days, I think you hear, and some people think that actually palliative care is only for cancer. No, but also we saw sickle cell, people who need pain management, really continuously. And then the approach extended with the rising number of non-communicable diseases, which are sometimes called lifestyle diseases, the way we live with people with conditions of the heart, conditions of that really need somebody to move along with someone. And so the approach has been here for 30 years. The association was formed in 1999. And what formed the basis of the association was that once the approach started, then the founder, Dr. Anne Merriman, and the nurses and the doctors she worked with found it very important to create a forum where people who are trained in delivering this care that I'm talking about would always meet, discuss, and see how many patients they are seeing, and see what the problem is, and devise ways of reaching across the country, and make sure that this care is not only in Kampala, in central Uganda, but also in other regions across districts. Because as you know, our healthcare system is still functioned in a way that when you are sick, you come to hospital. When you need help, you come to hospital. Now, everybody thinks that that's possible for everybody to go to hospital, which is not the case. We have some people who are in homes who are really sick. They don't have transport, they don't have the knowledge of where to go, so they are in their homes. But also we have people who have been through the healthcare system, they have been treated at the tertiary level of the healthcare system. They are not going to cure. So the medical people say you are discharged not to go home to cure, but to go home on your deathbed, if I can say that. So the Palliative Care Association of Uganda was formed to make sure that it accelerates the access, the spread of this form of care, which we have been advocating more strongly that it should be home-based care. That if somebody is at end of life, and we have done research, and research has shown that the majority of the people, especially the older persons, they would really want to die at home if at that point. Let there be a health worker, a medical worker, working out with the patient and the family, so one is not really in agony and suffering, so that the dignity of the person, even at that point of transition, because sometimes we all want to assume and believe that, you know, death is for a certain group of people, it won't come to us. But we are living human beings. At one point in time, we'll transition. So that is why the palliative care approach is very important in the community.
True. So let's talk about a little bit about morphine, oral liquid morphine. How available is this morphine? You know, when people hear about it, isn't it something that can be abused and used even if I have a very small pain and I can access it and it's available? How do you regulate its use for only palliative care and it's not misused by the public?
Yeah, thank you so much, Esther, for that question. So there are always a lot of myths surrounding any form of medicine. And in our country right now, we see pharmacies and drug shops, and somebody can walk in and buy any medicine that they want. And we always discourage that. We ask people to go and make sure that they get medicine once it has been prescribed by a qualified health worker. Specifically for morphine, morphine is in a group of medicines called Class A medicines or drugs. It is not available for anybody to say I can go and buy from the pharmacy. Mm-hmm. In fact, if you find it at the pharmacy, then that means there's a mistake. There's something that is illegal at that point in time, because it's really controlled under a law by government called the Narcotic Drugs and Psychotropic Substances Control Act. And the National Drug Authority will be against that, having it on the shelf for anybody to pick, because it's prescribed by a qualified health worker. For morphine, in our country, the oral liquid morphine that is popularly used among for pain management among palliative care patients is procured under government funding, and so patients access it for free. We have been appealing that oral liquid morphine should not be bought from health facilities. Our association has been at the forefront of coordinating the supply chain. So this medicine, which is a government medicine now, which is a Class A medicine, meaning it's not supposed to be just accessed by anybody. It should be under lock and key in pharmacies, in hospitals, and should be accessed only for patients who have received a prescription from doctors or nurses and clinical officers that have been trained and have been certified to give the medicine. Is available in hospitals for sure for pain management. It is not abused because it has strict laws that govern it. And once a patient is given this medicine, the health worker takes them through on how to make sure they measure their doses and they take it rightly. So we always encourage patients to ask whenever they need and they see that the medicine is not working for them or they have other needs. We also do not encourage that the medicine is shared, because no amount of medicine is actually supposed to be shared. It has to be taken by the patient to whom it has been prescribed. And we always encourage the health workers especially who have not interfaced with the idea and who have myths and misconceptions about the medicine to contact the Palliative Care Association of Uganda for what we call a continuous medical education session. Mm-hmm. So the Palliative Care Association of Uganda has been going to the countryside. We are now talking about 25 years of PICA. One of the biggest things we have done very well is to go to health facilities. Like in 2023, we went to 178 health facilities, working out with teams to talk about their continuous medical education on pain management, on using medicines like opioids, including oral liquid morphine, on making sure that the myths and misconceptions are dealt with. And the oral liquid morphine that we talk about, the patients are allowed to use on the ward when they are admitted within the hospital, but also to take home. It is in a bottle, it is in a liquid form. And so patients, as long as they move around with their prescription, because if they don't, then the police who enforce protection against misuse and illicit use, they may arrest them. So this medicine is paid for by the government of Uganda, reconstituted in our country, distributed by the national medical stores and the joint medical stores to private facilities, and accessed by patients, and we say free of charge, but of course government pays for it. Thank you.
Thank you, Mark. And in terms of, so you say it's not everybody who can administer it. They are trained people. And they're trained people who are supposed to come to our homes or to people's homes and do this palliative care.
Yes.
So I wonder, we do not have a large number of healthcare workers in this country. How many trained palliative care nurses and people do we have? And is there a growing number? Are you training more? Where are you training them from?
So thank you so much. Also a very good question. Uganda has been at the forefront of palliative care training in the continent of Africa. We have the Institute of Hospice and Palliative Care in Africa, in Makindye, where the people who train in palliative care for health workers, one can get a diploma, one can get a Bachelor of Science in Palliative Care, one can even get a Master's of Science in Palliative Care. We also have, and the institute is affiliated to Makerere University, so the degrees and masters are offered by Makerere University. Now, we also have a diploma in advanced palliative care nursing, which is specifically for nurses, which is at the Mulago School of Nursing and Midwifery. And it is the Palliative Care Association of Uganda that has been offering scholarships and that actually supported government to start this diploma in palliative care nursing. And the nurses are registered by the Uganda Nurses and Midwives Council and licensed to go and offer palliative care. Now, our country is short of how many people are trained, because we talk about over 300 people so far trained. But when you look at the healthcare structure, our health, from health center to the national referral hospitals or even the specialized facilities, we talk about over 6,000 health facilities in our country. So if somebody talks about 300, really that's a drop in the ocean. But the good news is that in 107 districts so far, we have at least one qualified palliative care health worker. That leaves around about 40 districts which don't have any hospital or facility offering palliative care. Now, as an association, we have been advocating to the government and to the other stakeholders to support scholarships and training for health workers. Because as you asked rightly, for example, for the prescription of morphine, somebody has to be having a certificate, and this certificate has been going for people who have a diploma and above. So for the nurses and clinical officers, why the association and the palliative care champions and advocates had to say we need to advocate for them to be able to prescribe this medicine is because we know that there is a big gap on the doctors to patient ratio. And all the other medicines are prescribed by the doctors, but we know that the doctors are so few. Now, the approach that I talked about, caring for people until end of life and even in bereavement, you'll find very few doctors who are able to do home care, who are able to do community outreach. But the nurses at least are more. So that's why we advocated that the nurses can prescribe and they can go to the community, they can go to the home. And so in our country, we still need more people. Like I told you, 40 districts without a palliative care service. I told you that we have at least 300 health facilities which offer palliative care, but some of them in the districts you will find, they are not really vibrant. You'll find that in a whole district, maybe there is only one health center for, and there is a one trained palliative care nurse at a health center for, who is actually not necessarily recruited and retained as a palliative care nurse. They are recruited as a midwife or as a registered nurse, and they are also juggling the palliative care component. And because our healthcare structure is not going to the community, at least for the public service, for the public healthcare, then it becomes difficult for them even to reach the patients who are within the facility, the vicinity of the health facility. So it's important that we really stress the need for this service, which is still big in our country, that many people, even after 25 years of the Palliative Care Association of Uganda, after 30 years of the palliative care concept being introduced in Uganda, we still have people in families, in the community, dying in pain and agony. We still have many people who are talking about witch doctors and going traditional healers and they are not seeing health workers come to see them. So the need for palliative care education is big, and not only for health workers, but also for the people. I'm glad we are now on TV able to speak to many people. Some people could be perhaps hearing the word palliative care for the first time. So it's important that we reach. And the more we reach the community, the more we are able to empower people to know their needs, the more we are able to work with families which are looking after people who are sick, the more people will be able to speak to their leaders, to be able to put budget allocation for these services, and be able to move in the right direction.
Okay, so what would the ideal situation be? Would it be like one palliative care nurse per district, or what is the ideal situation so that everybody who is in pain and needs to access palliative care, or who is at the end of life or needs it actually, is able to access palliative care?
Thank you so much. The ideal situation should be that at each of the health center 3 in our country, we have a qualified palliative care service provider. In this case, a palliative care nurse, because we know that at least nurses are available and they can go up to health center 3. In fact, even doctors are available, but we know that the nurses could juggle. They could be more than the doctors. At each of the health center 4s, we could have a palliative care qualified person. At each of the general hospitals, at each of the regional referral hospitals, at each of the national referral hospitals, there should be a palliative care team. So a palliative care team at the specialized facilities, a palliative care team at the national referral, at the palliative care team at the regional referral, a palliative care team at the hospital, the general hospital, and a palliative care provider at the lower facility. You know why? Because palliative care should be integrated within the primary health care component. As I told you, that palliative care is best offered at home, that where the person has been discharged. Recently, we have had an initiative where we are supporting children who have cancer, who suffer cancer and have been enrolled on treatment. The nurses who are members of the Palliative Care Association and are working at the Health Center 3 and Health Center 4 level, which facilities are closer to the community, because now we are talking about sub-county and division level where they are. They will be knowing very well the child who has been diagnosed with cancer. And so they will be able to follow up if this child has been diagnosed and started on treatment at Uganda Cancer Institute. There is something they call treatment abandonment, that the child starts treatment and then abandons the treatment because they lack transport, they are not able to follow up, because the parents who were caring, now they divorced, or because there is a misunderstanding. You know, when there is a sickness in a home, and then the father says, this is your child, and the mother is really struggling to find transport, to find food, to find care for this child. Now, because the nurse at the Health Center 3 is the one who referred this child through the process to get the investigation, the treatment, they will follow up to the home, sit down with the home. And because the palliative care is an approach that has a team, they will call in the spiritual leader. Because we are a spiritual country, a religious country, they will call in the community leader. They will call in the volunteer. The child will come back to find treatment, because the children are getting treatment at UCI free. But the majority of them will abandon because of the problems within the navigation chain. So the ideal situation should be that in our country, these palliative care teams composed of professionals that I talked about should cascade up to Health Center 3. That's when we will know that palliative care is fully embedded within the primary health care component, that people in the homes and the community are receiving the care, that people who are within the community know that this service is available. Wow. I thank you.
So you talked about scholarships.
Yes.
What sort of people are these that get these scholarships to go and train in palliative care, the ones you give to? And is it only you, PICAO, that is offering these scholarships, or there is another association or organization giving them to people?
Yeah, so I'll be, thank you so much for that question, and I know I will have to wrap up. The scholarships that the Palliative Care Association of Uganda has been giving or is still giving, we have two modes of scholarships. Right now, we give research grants to people who are doing their master's degrees and PhDs and have ethics approval. They can reach out to the association. On our website, the Palliative Care Association of Uganda website, we have put a call, and we will support your research once it is in line with our research agenda. The second category of people are registered nurses. Now, these are people with diploma. They will be doing an advanced diploma in palliative care nursing, or they are doing a diploma in clinical palliative care. We also have a call on our website. We always publish that, and annually we have been able to support. We also support people who are really deserving. They have started their Bachelor of Science in palliative care and may not have enough to continue. So we have been supporting those. Annually, for the last 5 years, we have been giving scholarships up to 30 people. Now, for the masters, for research, we have few applications. And we encourage people to look out for the Palliative Care Association of Uganda research agenda and look out for areas of interest, as long as you are doing a course that is healthcare related or humanities related, because palliative care is not only a business for the healthcare workers, but business for everybody, because after all of us, we are on a journey to aging, we are on a journey to that condition that may lead us to transition from this earthly life. And so palliative care is everybody's business, and we encourage people to look out for more information and contact us.
Thank you very much. And lastly, we are talking 25 years now of palliative care, of PICAO as an association. What future plans do you have, and what new things should we look out to now that you are celebrating 25 years?
Thank you so much. And we are very grateful to God for the opportunity that our association has risen, and we have lived, and we started in 1999. It is completely good that we are celebrating 25 years. From we have seen growth in our association. Like I told you, the service has spread to up to, from that moment when we started at the Palliative Care Association, we have gone over 300 facilities in our country. We have lined up a chain of commemoration events. We are going to have a series of webinars, a series of founders to speak, a series of palliative care providers to speak, patients, caregivers, the policy makers, the hospitals which are offering palliative care. And I really would like as many possible that you people can join us, to come, to become members of the association, to join our communication, to make sure that you get in touch. You can reach PICAO on our toll-free line on 0800 399 100. I can repeat that. It's toll-free. It's 0800 399 100. When you call us, we will let you know about where to find a service. We have come up with a palliative care directory that tells you which palliative care provider is in your community. We are coming up with a digital information app that you can have it on your phone and know where to go to find a palliative care service, but also to be able to learn about palliative care and the service. We are linking up with regional committees. We have 10 of them across the country to make sure that we disseminate information. We are glad that we are being hosted at this digital TV, and we would like to do more to reach out as much as possible. Our plan as we go into the next 25 years is that we will make sure that people in the community are empowered, that they know about the service. Our plan is that we will see more research, more data for palliative care. Our plan is that more health workers will be trained, and we'll see more palliative care going to the community. That even internally as an association, our scientific conference, which comes biannually as the biggest regional scientific conference on cancer and palliative care, expands more, and more people and more research papers are published. I thank you so much for the opportunity.
Thank you very much, Mark, for coming to this show to talk to us about palliative care in Uganda. And we are very proud of the 25 years of achievement you have had. And we look forward to having you again next Tuesday or another Tuesday to talk to us about palliative care in Uganda. Thank you.
Thank you.
The Alternative Dig Talk. Real issues, real talk.
Hey Teddy, have you noticed how little attention science and health issues get in the media?
Totally, Edgar, yet science information is very important.
Yeah, for sure. That's why the Health Journalists Network is here.
How can they help?
They are a group of journalists dedicated to advancing public understanding of healthcare issues through impactful reporting on health and science.
Oh, really?
Yes, they meet up every month with scientists and researchers, policymakers, and activists at the science media cafes. They then relay what they discuss to the public.
Does that benefit us?
Oh yes, very much so. This helps with health and science literacy for a healthy Ugandan society.
Okay. I love getting informed about science and health issues. Health information makes all the difference between life and death. I'll look them up and engage them.
That's great. They are based all over the country.
Oh, okay. That's interesting, and they should be making real impact.
They are empowering health communities through journalism. Journalists can save lives just like doctors.
The Alternative Dig Talk. Real issues, real talk.